Good afternoon. The topic for today's medical problems in dentistry. There are a series of lectures that's going to be taken from henceforth. The first in line is going to be cardiovascular disease, followed by respiratory system, endocrinology, hematology, and so on. So this topic will cover more on the medical problems that will be present by the patient in the dental clinic, and how you are going to overcome those medical problems and plan your treatment based on the medical problem presented to you. The topic learning outcomes are: plan a surgical treatment taking into account the patient's social, psychological, and medical status. Assess whether the patient medication will affect the proposed treatment, including prescription of drug required for surgical procedure and required period. Differentiate those patients who are suitable for treatment in the dental clinic from those requiring hospital care. Explain the features of common medical conditions that will complicate dentistry and suggest remedies for them. Analyze results of physical evaluation and get clues to underlying medical pathologies. Before we start, let's see the basics of the cardiovascular system, mainly the physiology. The cardiovascular system is that the blood transporting network comprises of heart and blood vessels. So the blood becomes oxygenated in the lung and travels into the pulmonary vein to the heart at the left atrium, from where it flows into the left ventricle through the mitral valve. Blood leaves the left ventricle through the aortic valve to the aorta and is distributed via the arteries throughout the body and is collected into the vein and returns via the vena cava to the right atrium. This then flows through the tricuspid valve to the right ventricle. Blood leaves through the right ventricle through the pulmonary valve to the pulmonary artery, and then hence the lungs, where it gets up the oxygen. Why you need to know the basics of this physiology is to differentiate between the various conditions that exhibits because of this oxygenated blood and deoxygenated blood, especially in case of congenital heart diseases and so on. Before that, we can see the causes for the cardiovascular diseases. So the causes can be either an organic heart disease or functional disorders. The organic heart disease is nothing but the organ itself has a problem, like the heart or the arteries, or the arteries that supplies the heart, or the structure of the heart. Whereas the functional disorder is that the function of the heart which gives some form of anomalies like hypertension, or it can go to tachycardia, bradycardia, arrhythmias, or there can be any change in the circulatory volume like hypovolemia, etc. So based on this, the classification of cardiovascular diseases can be congenital heart disease, acquired heart disease, and cardiac failure. We are going to see in detail about the congenital heart disease and acquired heart disease in this lecture, because these are the conditions which we will come across in a dental clinic, where they'll come for any form of dental procedures that has to be carried out, and what will be our decision whether to take up them for extraction or any other dental procedure that is needed at that point of time. So coming to congenital heart disease, congenital heart disease are the most common type of heart disease present in children, present in about 1% of live birth. So congenital heart disease include a wide variety of structural defects that can lead to malfunctions such as arrhythmias or flow problems, vessel or valve stenosis or obstruction, and septal defects, strains on the myocardium. The heart disease can be cyanotic or acyanotic. Cyanotic means there is right to left shunting, and in general these are more severe defects, and the other one is acyanotic, which is less severe. Cyanosis and hypoxia can lead to neurological deficits and polycythemia and other systemic infections. Why the cyanotic is as serious as when the heart has a deoxygenated blood from the right and then it mixes with the oxygenated blood, then it becomes more severe. So the deoxygenated blood enters into the circulation again without being oxygenated, without going into the lungs and get oxygenated. So that is the reason it is more severe. So once the blood goes from the right to left shunting, then the cells think that there is not enough oxygen to be carried by the cells. So the bone marrow starts producing more number of RBCs and other cells for carrying out the oxygenation. That's why there is always polycythemia that occurs. So always cyanosis is going to be a serious problem than the oxygenated blood which comes into left to right shunting. The different types of congenital heart disease are listed in this, which is cyanotic and acyanotic. So you got a lot of syndromes and other valvular problems on cyanotic, whereas in acyanotic there is only a few like aortic stenosis, bicuspid aortic valve, and so forth. What are the causes for the congenital heart disease? Most of them say that it's due to genetic cause or metal infection or metal drug use like anticonvulsant or alcohol. And there are also some syndromes which could cause congenital heart disease like Down syndrome, Helen-Döhler's, Frederick, etc. The common clinical features of congenital heart disease are cyanosis, finger clubbing, pulmonary hypertension, polycythemia, hemorrhagic and thrombotic tendencies, hyperviscosity syndrome, chronic hypoxia causing decreased neurological function, higher incidence of systemic function. Coming to our area of dental aspects, what we should be aware of in such cases who's undergoing that. If there is an emergency, you need to handle them. So all staff has to be trained with BLS or basic life support or cardiopulmonary resuscitation. Dental care with stress reduction protocol and with good analgesia, limiting the dose of epinephrine, though there is a theoretical saying of that epinephrine increases the heart rate. Patients with cardiac arrest should be treated in late afternoon than early afternoon appointments because the incidence of most of the cardiac diseases are in early morning. So effective painless LA is essential. An aspirating syringe should be used to give LA since adrenaline and epinephrine is anesthetic entering the vessel may theoretically cause rise in blood pressure or precipitate arrhythmias. Drugs may affect the dental care. So the most important aspect of dentist is to consider how well the patient's heart condition is compensated. Patient with stable heart disease receiving atraumatic treatment and localization can receive treatment in the dental surgery itself. There is no need for any hospital-based procedures. So in case of cyanotic congenital heart disease, there can be polycythemia related bleeding disease caused by thrombocytopenia, platelet dysfunction, coagulation defect, and excessive fibrinolytic activity. Thus, platelets may be reduced and the hemocritic prothrombin time and activated thromboplastin time will be increased. So, oral abnormalities associated with the cyanotic congenital heart disease are delayed eruption of both dentitions, greater frequency of positional anomalies, enamel hypoplasia, skimmed mill appearance, and there is gross vasodilation in the pulse, greater caries and periodontal disease activity because of poor oral hygiene and lack of dental attention. Then mucosal lesions of unknown etiology may appear. Infective endocarditis is one of the organic diseases that has been exhibited. Infective endocarditis is rare but potentially a life-threatening infection, predominantly affecting damaged heart valves. So that happens either due to vascular endothelium rupture, platelet fibrin deposition, non-bacterial thrombocytic endocarditis, and those adherents, or it can be due to mucous membrane trauma, then bacteremia and adherents, colonization and vegetation. So the right one exhibits the picture where there can be colonization of the bacterial which causes endocarditis of the valve. The patients at the higher risk from endocarditis are with prosthetic valves, previous infective endocarditis, complex cyanotic congenital heart disease like phallus tetralogy, or surgically constructed systemic pulmonary shunts, or mitral valve prolapse, or regurgitation or thickened leaf. The next is about the acquired heart disease. So we saw about the congenital heart diseases and how they are managed dentally. Now we are going to see the acquired heart diseases. In acquired heart diseases, we are going to cover mostly on in myocardial infarction, angina pectoris, and then about the functional problem of the heart like hypertension. So ischemic heart disease or coronary heart disease is the most common and important cardiac disease and the major killer of the developed world. Ischemic heart disease is common and more potentially fatal. Stress and anxiety can precipitate cardiac events. These are the two key points that you should always remember when you are treating a patient who has come for a dental extraction or any other dental procedure who gives a history of any heart diseases. So your treatment has to be targeted towards relieving of stress and anxiety as the first line of order. So the common clinical features that is presented by the patient with ischemic heart disease includes breathlessness, chest pain, palpitations, cyanosis, clubbing, and from measuring the blood pressure, from palpitation of the pulse, and from listening of the heart. Serious heart disease is not always symptomatic, and patient can die suddenly from myocardial infarction despite having experienced neither chest pain nor any other symptoms. So you always to be watchful when you are treating a patient with MI or who had an incident of an MI or who was reported with a cardiovascular disease. Also, the patient may manifest cardiac disease and have signs and symptoms effectively controlled so that they have superficially appear well. Often, only the drug history will give you a clue the nature of their cardiac illness. So, always go through the drug history and check whether the patient is on any antiplatelets or any anticoagulant therapy to confirm their cardiac status. So, this chart will give you the risks of artherosclerosis, where you see what are the primary risks, the secondary risks, and what are the blood profiles that will give you the risk factors for the artherosclerosis. The second thing is about angina pectoris. So angina pectoris is the name given to the episodes of chest pain caused by myocardial infarction or ischemia secondary to coronary heart disease. The usually underlying cause are atherosclerotic plaque that rupture with resulting platelet activation, adhesion and aggregation and thrombosis, impeding coronary artery blood flow. So if this is complete occlusion, then it becomes a myocardial infarction. So the picture shows how the plaque is there on the coronary artery, narrowing down the lumen of the vessel which supplies the heart. The clinical features are the precipitating factors that cause angina pain are physical exertion, emotion, stress caused by fear or pain, leading to adrenal release of catecholamines, unconscious tachycardia, vasoconstriction, and raised blood pressure. Consequently, an increased cardiac workload is accompanied by paradoxical drop in blood flow and myocardial ischemia occurs, resulting in angina. The general management for angina is the patient will be always on aspirin or combined with aspirin and clopidogrel, or they'll be on lipid lowering drugs which can reduce mortality rate in patients with coronary heart disease. They'll be on long acting nitrates, isosorbent mononitrate, and calcium antagonists are being used. The management of angina is, the surgical management is PTCA with stenting and CABG. PTCA is percutaneous transluminal coronary angioplasty, which is done in patient after doing an angiogram, and if there is occlusion of artery less than 80% or 70 to 80%, then they do PTCA. So they do a angioplasty. Angioplasty with stenting is done if they feel that after doing the angioplasty again the vessel collapses and it cannot maintain the patency, then they do stenting along with PTCA. Whereas CABG, coronary artery bypass grafting, is done most commonly in a patient where the occluding of artery is more than 90%. So they take the bypass either from saphenous vein bypass, radial artery bypass is taken, and then grafting is being done to establish the blood flow to the heart. What are the dental consideration in patients? Again, the patient should be certified all with CPR to give them an emergency care. Stress reduction protocol, as I already mentioned, is most common. In all forms of cardiac diseases, stress reduction is the primary key. And then limiting the dose of epinephrine. Theoretically, patient with cardiac should be treated in late morning or early afternoon appointments. The same LA is painless. Aspirating syringe should be used. And the drugs that may affect dental care should be avoided. Gingival retraction cord containing epinephrine and adrenaline should be avoided. Preoperative GTN and sometimes oral sedation are advised. The most important aspect of dentist to consider is how will the patient heart count is compensated. So you should know what is stable angina and unstable angina to derive your treatment plan. So for anything but minor under local anesthesia, the physician should be consulted. In case of stable angina, elective dental care should be deferred until the physician has agreed to it because of the risk of infection. In stable angina, consideration should be given to any other complications such as beta blocker therapy, hypertension or cardiac failure. Whereas in unstable angina, preoperative GTN sublingually or by inhalation should be given together with relative anesthesia, monitored by pulse oximeter. Patient with stable angina should be reassured and possibly sedated with oral diazepam. This is one way of stress reduction protocol. Our patients with unstable angina best cared in hospital and intravenous nitrate may be indicated. Prophylactic administration of GTN may be indicated if the patient has angina more than a week, once in a week. Emergency dental care should be least invasive possible using preoperative GTN sublingually or by inhalation together with relative anesthesia monitored by pulse oximeter. So in case of post-angioplasty, elective dental care should be deferred for 6 months. Emergency dental care should be done only in hospital setting. Patients with coronary artery and bypass grafting, patients should not receive any adrenaline containing LA since it may precipitate arrhythmias. For the first couple of weeks after surgery, the patient may feel severe pain when reclining in the dental chair and the side effects of the surgery because of the rib that has been opened up for doing open heart surgery. So in colloquial term, the coronary artery bypass grafting is called as open heart surgery. Patients with vascular stents that are successfully grafted, the main point was already been discussed. So it may be prudent to provide antibiotic coverage if emergency dental care is required during the first 6 weeks post-operative. Elective dental care should be deferred. Patient may require long-term anticoagulant medication. Appropriate action is required to deal with any bleeding tendencies. Coming to myocardial infarction, chest pain described as pressure sensation, fullness or squeezing in the mid portion of the thorax, radiation of chest pain in the jaw, shoulder, arm, associated dyspnea or shortness of breath, associated epigastric discomfort with or without nausea and vomiting, associated sweating, syncope or near syncope without other cause, impairment of cognitive function without other cause are the features of myocardial infarction. The dental management, if the patient gives a history of myocardial infarction or if it is going to be less than in 6 months, then reinfarction of 50% has been reported in major surgery. Simple emergency dental care and LA may be given during the first 6 months after MI, but opinion of the physician should be sought first. 6 to 12 months, reinfarction of 20% have been reported in major surgery and about 5% in minor surgery done during this period. Elective simple dental care can be avoided or safely to minimize pain and anxiety. Higher risk procedures such as elective surgery may need to be deferred. If it is more than 10 months, reinfection of 5% has been reported in major surgery done during this period. The level of risk will depend on the type of intervention. Surgery is higher risk than conservative dentistry. Anxiety and pain must be minimized, and the physician may be advocated preoperative use of GTN. The most common functional disease that you come across will be hypertension in your day-to-day practice in dentistry. So hypertension is nothing but your persistent raised blood pressure. The blood pressure is a byproduct of cardiac output and peripheral resistance and is depending on the heart and vasculature, anatomic nervous system, endocrine system and kidneys. These are the list of causes of hypertension. The secondary hypertension, the renal disease, endocrine condition, cerebral disease, or coagulation of aorta, drugs and sleep apnea. Of course, the blood pressure has to be recorded before any form of surgical procedure has to be carried out. So there is a manual technique for recording blood pressure. So probably this is already been will be demonstrated when you come for your clinics, how it has been, or in your year 3 general medicine, general surgery, they would have described how or demonstrated how a blood pressure has been recorded. So just this slide is just to brush through your basics, how it has to be done. So dental management of hypertension. So American Society of Anesthesiologists have said a few guidelines if there is going to be blood pressure or the values of the blood pressure in case of hypertension. If the values is going to be less than 140 to systole and less than 90 is the diastole, they graded as ASA1 and then routine dental procedure can be carried out. If there is going to be 140 to 159 and the diastole is going to be 90 to 99, they grade it as ASA2, hypertension stage 1, recheck blood pressure before routine dental care and then proceed with the procedure. If it is going to be 160 to 179 and the diastole is going to be 95 to 109, it's staged under ASA3, hypertension stage 2, recheck blood pressure, seek medical advice before routine dental care, restrict use of adrenaline, conscious sedation may help. If the blood pressure is going to be, the systole is going to be more than 180 and the diastole is going to be more than 110, it's graded under ASA4, hypertension stage 3, recheck blood pressure after 5 minutes, quiet rest, medical advice before dental care. Only emergency care until BP is controlled. And when you are doing the procedure, avoid vasoconstrictors. So it is clear and evident that any blood pressure with a systole of 160 and a diastole of 95 and above or 100 and above, should any form of dental procedure has to be avoided. The same basic protocol of stress reduction and you getting you trained and scheduling of the appointment has to be followed for hypertension as well. Another one is about arrhythmias. This is also a form of functional disorders. So there are different types of arrhythmias. The medical management of arrhythmias, the most commonly advised drug is a beta blocker, or if they wanted to change the pace of the arrhythmia based on the location, they place a pacemaker or a defibrillator is being given for management. So what is our relevance is if the patient comes with a pacemaker for a dental procedure, what are the precautions we are going to take? So there will be interference of pacemaker if there is an high frequency external electromagnetic radiation, ionizing radiation, ultrasonic and electromagnetic interference. So the most thing we are worried about is ultrasonic. So these are some of the list of instruments in dentistry that can interfere with cardiac pacemakers and which doesn't. So procedures where interference is unlikely are amalgamators, composite light cures, dental chair light, dental handpiece, dental radiography unit, electric toothbrush, electronic apex locator, electronic pulp tester, microwave ovens, piezoelectric ultrasonic scalers and sonic scalers. Whereas the procedures that interfere are likely diathermy units, electronic dental anesthesia unit, electrosurgical units, ferromagnetic ultrasonic scalers, lithotripsy units, MRI, TENS, and ultrasonic instrument baths. The only safe procedure under such circumstances is to avoid the use of such equipment, whereas whenever a patient is being with pacemaker is being treated, patients should be treated in a supine position. Electrical equipment must be kept away 30 cm away from the patient. Rapid repetitive switching of electrical instruments should be avoided. Diagnostic radiation and ultrasonography have no effect on pacemaker even with cumulative dose, but faulty equipment may cause problems.